So I'd like to introduce our next speaker, Dr. Ayis Pyrros. Dr. Pyrros is a colleague of mine at Duly Health and Care, as a neuroradiologist and an innovator in development of artificial intelligence in the field of radiology. He's published in multiple peer-reviewed journals, including The Lancet, Journal of American College of Radiology, and Nature. He's a wonderful colleague, very innovative, and very always positive to work with all of our clinicians. And he's going to be presenting on artificial intelligence in nutrition and in culinary medicine. Dr. Pyrros, thank you.
This is my format. Do you have a laser pointer or no?
There's a pointer. We'll just use that one forward and point it to over there.
Oh, pointer.
Yep. And remember, you have to tell us your favorite vegetable and your favorite fruit.
Favorite fruit by far is grapes, for sure. I'm Greek, and I don't know, my mom fed me a lot of grapes as a kid. So yeah, my name is Ayis Pyrros. I am a radiologist, so you might be wondering if they get lost. I did not get lost. I was invited here. So the question, of course, is how does this relate to what you're doing? And I'm going to show you some of that today. So my disclosures, some of my research was sponsored by Midrick. I do some consulting for 2 startups that are in the large language model space. Let me put my timer on because I want to run over. Make sure it's doing good. Okay, so but the outline of my talk today is just a little background on why I'm interested in nutrition and nutritional health. And we're going to talk about how artificial intelligence, specifically we're going to talk about large language models. So I really have 2 talks here. One about large language models, which you probably have heard about at this point, and then addressing basically the other part of it, which is going to be biomarkers and how these are going to be used in the clinic. And eventually you will be using some of these at some point. Okay. So I do work at Duly with Dr. Dungan. Thank you for the invitation, as well as Dr. Harlan. We are a large multi-specialty clinic, so we're composed of obviously family medicine, internal medicine, the whole gamut, as well as radiologists. And the reason I got interested in this is because we've had this transition from fee-for-service medicine to value-based care. And so a lot of the work I do in radiology is really driven, unfortunately, by the consequences of cardiometabolic disease. So we see patients, obviously, that have had, diabetes for many years, and they develop, dementia, renal disease, all the things that I get to see on the other end. And so it's frustrating for me as a radiologist because I like to have a job. I wouldn't like to see all these horrible strokes and other various complications. And we know that basically culinary medicine is probably the biggest lever that can get pulled in this area to help value-based care. So it's unfortunately difficult because as we switch from fee-for-service, right, the traditional go to the doctor generates a CPT code, that's going away. We're bundling all of this, so it's putting pressure on all specialties to provide additional input that could help manage a patient or population in a more beneficial way for the group, right? Reduce costs ultimately. That way. Okay, so there is a lot of hype, right? Oh, I think I skipped a slide here. The terms AI, DL, or ML. So you're going to hear these terms thrown around a lot. They're somewhat synonymous, right? They all kind of mean the same thing. People use the word AI to talk about, self-driving cars. Machine learning really represents the way we develop these algorithms, right? So you take a set of data and you sort of train the computer to basically do a task. Like the classic thing is a spam filter, predictive texting. And then really deep learning is the thing that's gets talked a lot about, because what represents the deep learning refers to a neural network, and this is sort of like a rudimentary simulation of a human brain. And what it's supposed to do is supposed to help with things like facial recognition, language translation, and this is the cutting edge stuff that everyone's been really talking about. So we talk about all of it. Really, in reality, the fun. I like this slide because I think it's kind of summarize what it is. When you're fundraising, it's a startup. They talk about AI. When you're hiring, it's ML, and when you're implementing, it's logistic regression. So these aren't really conscious things. They're really statistical models, just like any other kind of model you would use in your day-to-day clinical practice. So they get hyped a lot, but in reality, they're still mathematical models, and the same kind of issues that we'll see with those. Okay, so LLMs. Has everyone heard of GPT, I assume, at this point? You guys raise your hands. I'm just curious. Yeah, everyone. Okay, great. So you know what these are. These are large language models. That's what it stands for. They can do an amazing amount of stuff and things that I think you guys will find very useful. So they can take something, particularly summarizing, so taking a clinical document and making a quick summary. Some recent publications have shown that clinicians prefer the large language model summarizations rather than another physician's. They can obviously answer questions. They can do translations. So they can do quite a bit of functional work that a human can on text. The models are trained basically, people have said it's the internet. It's not necessarily true, but they've been trained on a large amount of data from the internet. Models like GPT, they have done a lot of work in using humans to also supervise the answer. So it's not entirely unsupervised, but that obviously costs a lot of money. And then the application really is everything, right? We're seeing these chatbots, but they're basically popping up all over the place. They are actually going to be in Epic, and I'll show you at the end. Epic is rolling out a lot of these features, and so I think the use is there. Having used them in clinical practice right now, we're experimenting with them. I think they have a tremendous amount of utility. So GPT stands for generative. It's a model that takes new outputs like sentences based on the input given. It's pre-trained, right? It's trained on this large amount of data like we talked about from the internet. And then this transformer, and this is basically the model architecture which enables it to understand the context of the words in a sentence. So the way this really works basically is you give it a bunch of words, the computer then translates these words into numbers. These are tokens. This makes it easier to deal with in the model. And then in essence, what happens is the words get embedded, right? This is how it generates a somewhat understanding of the word. So for example, the word cat and kitten, right? They're close together and they get sort of translated this plot inside the model itself versus dog or house, right? And you can see that the relation is somewhat expressed in how far or close they are on the graph. And then finally, the big revolution was called a transformer. And what the transformer really is, it allows it to basically, the big part of the transformer is they've added this attention mechanism that allows it really to generate relevant output. And there are a bunch of basically features that are used to modify how it generates that output. So really, let me see if I can hit play. Oh, no. Oh, sorry. I messed up. What did I do? Go back? All right, thank you. Apologize. One more. All right. So this is what really is happening. So you have a phrase. You want to hit, if you hit click it for me, it will play. It's a little animation here. Oh, okay, click on it right now. Playable? Oh, sorry, did it again. So the animation was supposed to show us is basically if you feed it a phrase like the quick brown, what happens is that text gets sent through the model, and that's that deep layer neural network we talked about. And in essence, it basically generates the next most probable word. So a lot of people have called this like a stochastic parrot. You guys have used Google. You type in a word, and it gives you the next possible, next likely word that's going to come along with that phrase. Like so, it goes the quick brown fox, and so it generates probabilities, and that's how it's getting the next word. So it seems it's very rudimentary, but in reality, it can do some really amazing things. We'll go to the next slide here. So here's one of these examples. This is a multimodal model, and what that means really, it's been trained on text and images, and what it does basically is it's designed to help with the dialogue, right? Which we know dialogues are really painful to do. We've probably all used MyFitnessPal. You do it for a week and you give up, right? And the idea here is that you can use maybe a camera on your phone and identify the food. And the results are pretty good. This is a smaller model that was sort of designed to work on a phone or a mobile device. And you can see basically they used images from Flickr. They do mention specifically that this probably won't work well in other countries because it's basically was geared towards the U.S. With these data sets they had. And that's a good point because, right, if you go to Europe or you have someone that maybe comes from a different country, that obviously these foods are going to look different and therefore it may not be able to identify them. And for the dietitians in the audience, I know everyone worries they're going to lose their job because of these things. That's probably not going to happen. This is a paper that came out recently in Nutrition talking about the credibility of dietary advice from GTP. And what they found that basically it can occasionally create really risky diets. Not surprising, right? It can put in inaccurately specified food quantities, calories, and suggest monotonous diets lacking in variety. The paper didn't evaluate GPT-4, and that's a key point to this, is that these models are constantly changing. Since I prepared this talk, they've come out with another version of ChatGPT-4. So they are constantly adding and developing, and it makes it actually hard to know necessarily what specific model will work well in every situation. And there's this issue of hallucinations and prompt generation or prompt engineering. And so basically the models occasionally, if given just very little input, will start making up stuff, and that does happen, and it's a real issue. Like for example, you could say, give me a reference for this food in the use of treating type 2 diabetes, and it will make up a reference that's totally confabulated. So that's a very important point. They are getting better, and the way they've addressed this is something called RAG. It's retrieval augmentation. So basically it searches the database to find a reference, not make it up itself. And so I think that's a key point, that these are techniques that are constantly evolving. So I'll go to the next slide. There we go. There are already a ton of these applications out there that exist. This is one called MenuBot. There's many of these that are out there. And the idea is they try to use these language models to help generate menus, essentially, create, recipes. I've had a colleague of mine who uses GPT in general and says it actually does a decent job. But there are many, many of them. And like I said, I found probably 10 just by looking around, and there are more. And patients are probably going to start using them. So my take-home point for you in this part is that basically you can use them yourself. So get familiar with them because, like I said, patients will be using them. The big question a lot of people have is, well, I want to use this on clinical data. How can I do this in the clinic and do it safely? The first option is Ollama. So this is basically a website. It's an open source project, and Facebook has developed this large language model called Llama. It's being used a lot in research. Ollama is very easy to install and use, so you can actually run it on a personal device. You don't have to send the data to the cloud and feel worried about that. And then, of course, if you guys use any kind of Microsoft product at work, you have like Teams, you already have access to something called Bing Copilot, which basically Microsoft has invested heavily in OpenAI, and that is readily available. So you can literally go to that website on your work computer and actually have supposedly a somewhat secure access to this model. And of course, there's ChatGPT, which many of you probably played with. And then the other site I want to point out is Hugging Face. Hugging Face basically is a sort of like a library of these models. So literally, if you go there, there are some people posting a new model literally every day. So some of which are related to nutrition, almost every radiology, any kind of specialty you can think of, there are models that have been sort of tuned to some of these applications. So it is an ever-growing, expanding field. And I definitely recommend you guys try Ollama if you want to use it for clinical purposes. I think it's a very viable option and solution, and very easy to use. All right, so some examples. I play with this, so let's see how this works. We take a picture here. There's a burger and a salad, and we ask it to generate. Basically, this is GPT, the latest version 4, and it gives you a relatively reasonable response. And you can see, it tries to break it up. It picks up on some subtleties here, but I'll show you where it fails. Let's say we have a patient that we want to create, put mine. Sorry, my take-home point was on top. You have a patient that you have a picture of their fridge, and so I say, generate some meal options from this picture. And clearly, it's making up stuff here. There's no Greek yogurt that I can see in the picture. Personally, I take that personally. I'm very offended by this. And then, I don't see salad in here. So you have to understand that basically they're good, but there's limitations in these. And so I think we want patients to basically come in with detailed logs and maybe information about their diet. And I think these will have a tremendous utility in that area. Simply put, they should simplify the process, but they can make stuff up. And so over time, I think they will get better. Okay. So now we're going to talk at the part where I do a lot of work and research in, and that's computer vision. So ironically, computer vision models have been around for some time. and they've gotten very sophisticated, and they're, I think, very mature at this point. And these are also neural networks. And the idea is that basically you can take an image basically and have this model classify or even predict some actual value from an image. They are used obviously in doing things like self-driving cars like we talked about, and a whole variety of applications, some of which I'm going to show now. So AI imaging biomarkers. So AI imaging biomarkers, the idea of this, and we're going to talk about opportunistic detection of disease, right? So why do I like this? You know, a lot of these things we're going to talk about, you can see on any image, right? We all order CTs and chest x-rays, or we've dealt with them in this profession. And we know that when we order them, oftentimes we're looking for a specific thing like pneumonia. But there's a lot of additional information in the image that could be leveraged to help patients in other areas. And that's kind of the idea behind opportunistic detection, that if you have this data, we can leverage it and maybe predict your risk for something like diabetes. And the reason I like this is because it's deterministic. The AI, you know, you give it an image and you give it the same image over again, it's going to give you the same number or the same result. Whereas if you give it to me or another radiologist, as you know, sometimes they might give you one result and it might be slightly different on a different day. And so that is an issue. We're stochastic as humans. We kind of, you know, change our minds sometimes. The AI is very fast, and that's something I want to emphasize with all these tools is that, you know, you can give it an image like a chest x-ray, and in under a second it can give you a prediction. And that's of value, because if you have a large, you know, practice or a large system, you know, hundreds of thousands of images potentially, this can get through them very quickly. And really the big value here, what we want to focus on, is the early detection, right? These biomarkers, we believe, can show subtle signs of disease before they're in the clinic, before they come to the hospital, and I think that's a key point. And they can even spot health disparities, and I have one thing at the end about that. All right, so why do we use a lot of these chest x-rays in this particular application? The reason why is because there's a lot of them to begin with. And the top 3 causes of mortality are found in the chest. So cardiovascular disease, lung cancer, COPD. You know, we know there's a lot of very important stuff there. And they've already been shown to predict things like, you know, biological age, mortality, comorbidities, and we've done some work on this disparities. So I want to emphasize that they're cheap and versatile, and that's a good thing. A lot of work has been done on MRI and CTs, but obviously like whole body MRIs are not something that we typically get. Oh, let me go back. Okay, so how do we develop these models? So at Duly, what we have, obviously we have this large database, a PACS system with a bunch of these chest x-rays, and then we also have Epic and this clinical data warehouse like Clarity, and you have all these codes, right? So we have these 2 massive data sets, and we have I think our average patients with us for around 10 years, and we're able to link these 2 together. And that's really the magic here, right? It's not only having just simply the images, but also these labels, and lots of them over a long period of time. And that's where these models can get very helpful and very useful. So combining the 2 is really the secret sauce here. So the loss function, you'll hear this a lot, and what this really represents in deep learning, right? You have a label like a BMI, and you say that the BMI is 30, and you feed an image through the model, and it predicts something. And in the training phase, it might predict something wrong. It probably will, like a BMI of 25. And the loss function really kind of represents the difference between what the actual true label is and the model's prediction, and it basically tries to, you know, teach the model or penalize it for doing the wrong thing, and that's how basically sort of over time adjusts the weights. So, and this is like linear regression, logistic regression. It's not very complicated things, but it's doing it obviously across multiple categories. And that's kind of what I want to emphasize here. A lot of these models you'll see now are what we call multitask learners. And so they're using not only just simply data about BMI, but diabetes. We used A1C. So there's quite a bit of information that's packed in there. And the goal of that is to sort of basically tune the model in on picking up on subtle differences that are going to be very important, some of which that we can see, some of which we can't see. So this is one of the models we've developed. And what it is basically we feed it a chest x-ray, and from this one chest x-ray, you can predict someone's probability. We treat them these predictions as probabilities of CHF, AFib, morbid obesity, COPD, vascular disease, and diabetes. Now, you might point out, you know, I don't need a model to tell me if someone's morbidly obese, and that's absolutely true, but we're putting that in there basically to teach the model about the concept of morbid obesity, right? That BMI of over 40. And likewise, the diabetes you can see here, these heat maps, what we're seeing, these differences are very subtle. You see a lot of overlap between all of them, but there are subtle differences that drive that help drive its prediction. So this is actually how it works when we run the model. Basically, we feed it a chest X-ray, and literally it spits out these numbers. So this is all it's doing, right? It's not telling you they actually have diabetes. It's giving you just a number. For example, we have like a 18, which represents, type 2 diabetes in this case. These are categories of ICD-10 codes we've used. And you can see here like 108 is vascular disease. That's what the color map looks versus 111, which is COPD. You might notice that there's more blue that's in the lungs, which would be obviously more related to lung disease. So we started using this early on. Unfortunately, during the time of COVID, the question, of course, we had is like what patients are at higher risk of developing hospitalization from COVID. And this is one example where you take all these markers, all this information from the patient that we generate from this image, and we can basically then start using it to predict risk potentially from someone developing COVID and basically getting hospitalized. This is another paper we did in the same spectrum on COVID, where again, we use all these markers that the model produces to predict the risk of mortality from COVID. So again, we all know that when COVID was obviously rampant and we're having issues, that the patients that were high risk, type 2 diabetes was definitely a key component of that. And having this kind of information is useful in that sense. This is, again, predicting mortality between, we were testing this between our patient population at Duly and at UIC. And again, we can predict mortality pretty well from just, just using the chest X-ray. So the area I'm going to focus on a lot was work that we published in Nature last year about opportunistically detecting type 2 diabetes. So why, obviously, I'm preaching to the choir here, why do we care about type 2 diabetes or diabetes in general? It's a major contributor of cost. Major contributor to other diseases, for example, cardiac disease, end-stage kidney disease, dementia, retinal disease, et cetera. And early detection may improve outcomes. And particularly now that we do have GLPs, which my colleague just talked about, there are obviously better treatment options. And chest X-rays are, like I said, common. So we have a lot of this data sitting around. So the real problem, obviously, I think we all know this, that the screening guidelines are pretty clear-cut. The U.S. Preventive Task Force, we know that patients that are over a BMI of 30 should get screened. The real problem is that basically it's such a huge percentage of the population. And so we screen a lot of them, obviously, but do we screen enough of them, and are they getting screened at the right time? And just using the BMI is not necessarily the best tool. And I don't think I have to, again, explain this probably too much, but BMI is really kind of a limited biomarker, right? There are lots of people that have high BMIs that are not going to be probably at high risk for developing diabetes or other cardiometabolic syndromes. And the point is that basically, you have your Schwarzeneggers out there and other people, and I think that kind of confounds the use of this as a really effective tool, but it's what we use a lot. So in this study, we were using a very large patient population. This is about 160,000 patients in our practice, around almost 300,000 X-rays. The model was based on something called ResNet, which is freely available, also came out of Facebook Meta. And we used quite a bit of labeling. So the labels were age, BMI, A1C, diabetes status, and a bunch of these other comorbidities that we talked about. Sorry, again, this was supposed to show up when I was clicking through, so I apologize. But basically, what we did was we looked at taking these markers and then comparing it to just controlling for other clinical variables. And so what I want to emphasize here, this is odds ratios from logistic regression. And the outcome here is the development of type 2 diabetes. And our outcome was basically, did they have an ICD-10 code for type 2 diabetes and or an A1C greater than 6.5 in our system? And what we found basically is that the arrow pointing to the far right, that CXR, which is chest X-ray deep learning type 2 diabetes line, that refers to our marker. And you can see how it outperforms, there's the BMI, which is basically, near zero. So this shows the kind of the power of this tool, basically, that you can take this X-ray and get this marker, and it outperforms data that you have that's typically lying around in the MR. And what we did after that was we compared it to multiple subsets or subgroups. And so some interesting data here, basically, poorly controlled diabetes. Again, something that we don't really have a test for necessarily, and I think it's interesting that in many cases, a lot of times the patients get accused of not doing maybe a good enough job on taking their medication or doing management, but the model is able to actually pick up on these patients just by looking at the X-ray. And the other subset I think that's interesting to many of you is this skinny fat phenotype. So we know that patients that have apparently normal BMIs that will develop type 2 diabetes. And in this case, the model performs very well. We got like a 0.89 AUC, which is kind of a measure of performance, versus just basically using those clinical variables of age and gender, sex, and so forth. And so the point here is that basically there's a lot of information here that the model can help us risk stratify these patients across multiple categories, which I think is beneficial for what we do. And another very important point, the models can have bias, and we did test our model across various ethnicity and race groups. And a key point here is that it performs relatively similar, but it's not perfect, right? Our patient population is about 70% white and then 30% non-white. And so those differences will affect the model's performance. So if you go to a different locale, we tested our model at Emory, and obviously a different distribution, that does affect the performance. So it's an important point to take home, that these models do have bias, and basically the bias is what data were they trained on. So this is another take-home point here, that we did test the model at Emory. This AUC, again, area in the curve, at Emory was 0.77 or 77%, and at Duly, or my home institution, 84%. So again, some of this has to do probably with technical factors, right? Different types of X-ray units are used, and also obviously patient demographics. But it does work. So of course the question is, how does it work, right? How do these models? What is it really doing? So I'd love to show this to you, but I guess there's no way to play the video. Yeah. So basically what this is a video, and it is an animation that shows basically when we take that chest X-ray and feed it through another model to sort of manipulate the appearance, what areas change that cause the model's prediction to go up or down. And what we found is that it's central adiposity. So it's fat around the heart, cardiomyostyle fat, fat that's near the liver and the cardiophrenic borders, basically the fat that's around the heart and the liver. Those things really drive the model's prediction way up. So it's really tuned in. It's very tuned into fat depots that are in the central body. And I think that's the important point here. It's what they say in real estate about anything, it's location, 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 right? And it's the same thing with fat, right? So where that fat is really going to drive risk. And the point is that we can see some of that through just a regular chest X-ray. So it's basically a body composition tool. And this is to show you guys, these are two examples, right? These are patients both in their 60s. This is a heat map with a model. You can kind of ignore the green blobs. But the point here is basically on the left, you have a patient that has high risk, and on the right, the patient that has low risk, right? So the patient on the left does have type 2 diabetes. I think you can appreciate the whiteness, right? The white areas around that patient, that represents adiposity. And so basically that patient is just simply bigger, and I can see that, and I think most of you can too. And on the right, the patient, clearly you see that black area around the patient, on their sides. That really shows us basically the patient's smaller. And so I think these findings are there. The real magic here is that the model can do it very fast and very accurately and reproducible. Or, I could see it, but I'm not going to basically be able to say with certainty, is it really, is there high risk or low risk? So the whole point here is that basically the information is there, just sitting in front of us, that we aren't really finding out a way to leverage it. And then we looked at how, when patients get these chest X-rays, some of them obviously didn't have a diagnosis of type 2 diabetes, and later on they got it. So this is over a course of 10 years. And what we found was that basically the average delay in these diagnoses was around 1,000 days. So they got a chest X-ray, and then about 1,000 days later, they on average, got diagnosed with type 2 diabetes. And so we know that these patients will progress in some cases. The question is, we don't know who. And I think this can provide us some indication of patients that may need more management. So it's sort of this whole needle in a haystack issue, right? You know that there are patients in your system or in your practice that are going to have issues that are going to progress, but which ones? And really the way that we can leverage these imaging biomarkers is to help identify some of those needles. Now, this is research that we're currently doing in conjunction with the University of Wisconsin, and it's a toolkit called Oscar. Actually, Ron Summers, who's at the NIH, is one of the primary developers of this toolkit. And what the toolkit is basically, it's designed to take CT data, the conventional CAT scan we've gotten in patients all the time, and it takes that CAT scan and basically segments it into pieces. So there's something called a unit algorithm, and that algorithm is designed to basically, measure things I could do. You can do this right now, right? You can go home and get a CT scan, and you can start trying to measure the liver. Obviously, you're going to do one cut and be like, I'm done. This is going to take me all day. This does it in about 2-3 minutes. And the point here is that basically we can get very precise values of, liver size, liver attenuation, if the liver's fatty, for example, spleen, bone marrow density. And what it actually does is it counts the vertebral body, so it can give you the precise readings or measurements at a specific level in the body. And we can get this data for, thousands of patients. So we've done this on about 60,000 patients in our practice. And that's the map on the left there to show you what it segments out. And on the right, that's the output it produces, basically. And so BMD stands for bone marrow density, bone mineral density. It gives you a calcium score based on the aorta. And actually, I think some of the other values aren't shown. For example, it does do visceral and subcutaneous fat measurements. So the one thing that I want to emphasize here is that we looked at this as a tool to predict mortality in patients. And if we go back, one of the areas I want to show you is the muscle. So it measures the paraspinous muscles as well as the oblique muscles at those levels as well. And when we look at this at predicting mortality, it's very good at predicting mortality. And you're going to say, well, what drives this prediction? So this thing on the left here is the nomogram. And what it shows us basically is the points that are assigned to each of these features that this model measures. The one thing that's actually off the scale and very high predictive value for mortality is muscle density. So I guess you probably heard of sarcopenia, this concept of patients losing muscle mass over time. There's another feature really called myosteatosis, or basically essentially muscle quality. So muscle quality is very, very important in predicting mortality in these patients, both at the University of Wisconsin and also in our data too. And it has this huge impact on survivability, right? So we look at this 10-year survivability, and for example, if your muscle density is low, you get assigned a very high point score. So basically, the lower it is, basically, let's say someone has fatty muscle that's around a density of 50 Hounsfield units, that gives you a huge drop in your mortality risk, your survivability. So the point here is that basically it's this feature that we don't really think about, but muscle quality, and this is, I think, an area of very active research that drives risk in these patients. And I want to point out that classic things like calcium score, for example, have a very mild impact on mortality in this model. This has been researched, of course, extensively. On the right, you can see basically normal skeletal muscle, and this on below, you can see adipose tissue that's been deposited in the muscle fibers, which again we can see on a CT image. So basically here we can see that one report showed that exercise and preferential reductions in this intramuscular fat can help obviously reverse this. And so that's the point here, that basically weight loss could potentially reverse this change. And it's something that I think obviously identifying patients that have this would be beneficial to target therapies for them. So really the challenge is really quick. I think I have just about, I have 7 minutes, great. The challenge really is combining all this data, right? So if you find a patient that has these abnormal markers, what do you do with it? And it's merging basically the nutritional science and all this culinary expertise into basically developing diets and or treatments that are going to be most beneficial to these patients. And obviously there's issues of building trust in these AI systems. There's cost, right? They require a decent amount of computing power to run and be effective, and so that's still being developed. What I mentioned before, Epic is actively working in this area. So Epic has a whole platform designed to handle AI models. They are doing a lot on the large language model side. They've actually worked extensively with Microsoft to integrate GPT-like features. So for example, you'll start seeing now this button that will give you access to an AI assistant, so that can help summarize your notes, it can help structure them. And then on the right, what we're seeing there is basically a prompt engineer. So basically you can see here, they can basically generate text from a certain prompt. You can say combine related goals into succinct points, and it basically can give these nice bullet points to a patient. So the real advantages of these tools, we spend a lot of time dealing with writing things up and instructions, and I think this could help automate some of that. So the example I want to leave you with basically is that, you have an AI biomarker. It shows increased liver volume, steatosis, this increased visceral fat volume, decreased skeletal muscle, low mineral density on the spine, myosteatosis. What do you do? What are the best dietary options? And so I think that is still an open-ended question, because we have this data, but we don't really have a lot of outcomes to link to it, right? We haven't figured out what treatments, the GLPs undoubtedly change fat distribution in the body. They are going to have effect on body composition, but we don't really have huge data sets to go back and reference because they're relatively new drugs. But I think that's the key point. And the other key point is integrating these, right? So they're already, you go to these websites like MDCalc, and there's literally thousands of statistical models out there, CHAT scores. There's many of these models, but how many of you really use those day to day? The answer is not many of us, because a lot of them require various things like, okay, I got to put in LDL, I got to put in an HDL, I got to find all these variables in the chart. That's not really useful. And Epic has done work in this to kind of make these models be more useful and integrated into the chart in the system, but it's still difficult. And so integrating these results, so if you get those results from this here, how do you get this back into the chart, and how can you leverage this in a way that's going to be useful? Okay. And then there are definitely privacy concerns in this area. I think that's being addressed by Epic pretty well. And then the cultural part of this is that, we do know that we have issues with different diets, and that's something that's, we have to take into account. These models are heavily based on US data. They won't necessarily work in other patient populations very well. And I think that's a key point that we have to take into consideration. So one of the things I'll leave you with, this is a paper we published in Lancet, and we found that the models can pick up on patient race, which is kind of crazy because I can't do that. And they can do it very, very well. And the point here is not that they can just pick up on race, but we don't know how to really account for it sometimes. The best way that we can kind of deal with it is by including that information in the model so that we have an idea. But it's an important point that this does actually can create a bias in these models. And so it's not necessarily something that we have to worry about specifically, but it's something that we should take in consideration. So really, when you start evaluating these tools, when they come to your practice, the first question you have to ask is, where did you get the data? What does the patient population look like? Does that look like my patient population? And ultimately, you're going to have to test these things out to see how they perform over a period of time to really see if they're beneficial. Okay, so the take-home points here are basically, I think these will be have a huge impact. The large language models will change our practices. There are, I think, a tremendous amount of opportunities in the opportunistic detection area, right? That, using these biomarkers to pick up on high-risk patients sooner. And the big question, of course, is what to do about it and how we can leverage these tools correctly. And then, the big thing here, I think, is really the value-based care component, that we can really enhance patient care by supporting disease prevention and these management strategies. I think this is kind of key to reduce cost, right? From a systemic population health perspective, that's where I think the big value is at. And these are my references. Thank you.